ugafata amaraso ukareba niba growth hormone yagabanutse. Niba itagabanutse rero, it is a sign that there is a tumor producing that growth hormone. So the treatment here, you give analogs to which will suppress or stop the release of growth hormone. Otherwise, another treatment is the surgery, treating that tumor itself. So the tumor is arising from the cells which produce the ACTH, this adrenocortical tropic hormone. So you know that someone having too much of this hormone, they have what called Cushing syndrome. So turayibona nyuma kuri adrenal gland ntabwo tuyitindaho hano. But here, this diagram is showing what happens in Cushing syndrome. So the pituitary gland releases a lot of ACTH, which will overstimulate the adrenal gland. And the adrenal gland will produce too much cortisol. And this cortisol, you see its effects. Changes in the mood to headaches, tiredness, reddish stretch marks, high blood pressure, abdominal obesity, but with thin arms and legs, acne around the neck, and so on. So all these are signs, but we shall come back on this. So also the tumors releasing TSH or LH or FSH also they can happen, but they are reported to be very rare. So then after these tumors, pituitary adenoma, which I say it is frequent because at Sashika we see frequent cases of pituitary adenomas. So hypopituitarism, so I'm mentioning it is anything which it is just a condition by which there is the insufficient production of hormones by the anterior pituitary gland. So, and they say that the symptoms will arise if more than 75% of the 75% of the pituitary parenchyma is lost. Symptoms there will be like an adaptation. So the cause includes a pituitary adenoma mass effect or craniopharyngioma. So craniopharyngioma ni ibijya gusa na pituitary adenoma ni tumor iza kuri muri iriya cellular region. Just you know the cell in the cellular region you have a pituitary gland. So if there is a tumor rising not from the pituitary gland itself around there, craniopharyngioma, it will compress the pituitary gland itself. Or the pituitary adenoma will compress the remaining part of the normal pituitary adenoma, causing then the pituitary gland to be insufficient. So hari ikintu bita Sheehan syndrome, ibi bikunda kugaragara ku badamu. I remember when we are doing the clerkships at Sashika, we had a case. So umudamu ubyara akava noneho yava bigatuma amaraso aba make cyane cyane pituitary gland ikaba affected. So it is explained here. There is infarction of the pituitary gland during pregnancy or delivery. So during pregnancy, the gland will double in its size. Birumvikana kubera ko izaba ikora za hormone LH, FSH, ahari n'izindi hormones ziriyongera. Nka growth hormone ishobora kwiyongera kubera ko umwana ayikeneye and so on. Noneho mu kwiyongera kwa size bitajyana no kwiyongera kwa vascularization, bishobora gutuma ibice bimwe na bimwe bitabona amaraso yagiye bikagira ischemia and then infarction. So blood loss during partition participates. So nibyo navugaga rero, iya partition uvuye igihe cyo kubyara, iyo ari kubyara rero agatakaza amaraso menshi, noneho niba pituitary gland n'ubundi yarasanzwe isufu itabona amaraso ayihagije, none izarushaho gusufura, then ischemia necrosis akenshi ni naho ibera, ntabwo iba mbere gitwi. So it is rare, ariko it happens, but it happens, and you cannot predict if it will happen or not. So that is an issue. So the woman then will present with poor lactation, loss of pubic hair, she will have fatigue and so on. So another reason for hypopituitarism is the empty cell syndrome or congenital defect of the cell. For example, there is a herniation of the arachnoid and the cerebrospinal fluid into the cell, which will compress and destroy the pituitary gland. So the pituitary gland will be absent. The cell in here pocket, it is empty because it has pituitary gland on a CT scan especially or MRI. So for the posterior pituitary gland, the hormones produced here, they are vasopressin and the oxytocin mainly. So antidiuretic hormone is also called vasopressin, as we know in physiology. Ngira ngo birumvikana vasopressin ikora ni antidiuretic, so it works on kidneys to decrease the quantity of water lost through urine. So niyo mpamvu muri kidneys hanyuramo litiro nyinshi, ngira ngo 180 n'abandi bikaneze, so remember physiology ku buri munsi, ariko urine it is usually around 2 liters or even 1 liter. So bivuga ko iyi hormone niyo ituma amazi atakara, ahubwo aragenda muri glomerular filtration, ariko yajya muri tubules zo hasi, proximal, distal and loop of Henry, amazi akaba reabsorbed agasubira muri bloodstream. So this is done by this hormone. So this antidiuretic hormone, and then oxytocin. So oxytocin mediates uterine contraction during labor and it releases breast milk. So kaibuzo kare vasopressin cyangwa nako oxytocin. Oxytocin igira inshingano ebyiri. Iya mbere niyo gutuma umudamu amashereka amanuka aza, siyo ituma ko amashereka akorwa ni prolactin, nayo ituma ba released ni oxytocin, ariko kandi kazikora no gutuma habaho ibise ku mudamu. So muzaya mubona umudamu yabuze ibise cyangwa se afite ibise bikeya bitafite imbaraga nk'umwana we yavuka, bamwongerera ibise. Imwe muri method bakoresha ni ukumutera oxytocin. It is a synthetic hormone just like this one made by the pituitary gland. So hari n'ibindi bimuha, hari umuti witwa cytotec, byo ni ibinini, ibyo ntabwo ari oxytocin, nabyo bituma ibise byongera. So it has the two functions. So then the diseases arising from these two organs, the first one is the diabetes insipidus. Insipidus ntabwo ari diabetes mellitus y'isukari, iyi ni ikibazo cyo kutagira antidiuretic hormone. So this is usually due to hypothalamic or posterior pituitary pathology. If there is a tumor, there is a trauma, there is infection or any other inflammation, destroying that part. So you see on this diagram, and we have two types of diabetes insipidus. Either ishobora guterwa nuko antidiuretic hormone nyine idahagije, aribyo nari maze kuvuga ahangaha. Icya kabiri, iyo ishobora kuba ihari ahubwo receptors zayo kuri adrenal gland, kuri kidneys zitakora. So iyo ngiyo niyo izaba nephrogenic. So we have a nephrogenic diabetes insipidus and the central because the problem is around the brain here. So here the pituitary gland doesn't make enough ADH. The kidneys make a lot of urine. So the urine will be lost. There will be no reabsorption. So bizarangwa n'iki? Ni umuntu rero aba afite sinye z'abadiabetike zo kugira inyota, kunywa cyane no kugira too much urine. Birumvikana n'ibintu. But when you investigate or you analyze the serum, you will find that there is hypernatremia and high osmolarity, of course. And while the urine, it will have low osmolarity. So the test which is done is called the water deprivation test, will fail to increase urine osmolarity. So this is useful for diagnosis. Otherwise, niba umuntu yari afite uramutse umwimye amazi, usanga urine osmolarity izamuka niba ari diabetes itari insipidus cyangwa ikibazo. So nephrogenic diabetes insipidus niyo navugaga rero yo iterwa nuko kidneys they are not responding to ADH. You can see that here on this diagram, the pituitary doesn't have a problem. You see that the problem is at the level of the kidneys. So the kidneys don't respond to ADH, they make a lot of urine. So usually it is caused by inherited mutations cyangwa se rimwe na rimwe igaterwa n'imiti umuntu yahawe lithium and demeclocycline and so on. So clinical features are similar to the central diabetes insipidus, but there is no response. There is no response to desmopressin. So kumuha desmopressin aha ntacyo bizatanga. Ni ukuvuga aha ngaha gutanga uyu muti uretse no kuba wamuvura, uyu muti uzaba ari of diagnostic also diagnostic purpose. Because if you give a desmopressin and the symptoms disappear, then it means the problem was the lack of vasopressin. If the symptoms persist, it means the hormone is there, it has no problem. The problem is its receptors on the kidneys. So we have also a syndrome of inappropriate ADH secretion. So here there is excessive production or secretion of the vasopressin. So most often due to ectopic production. Nabivuzeho mbere kuri lungs, and I mentioned the paraneoplastic syndrome igihe twarebaga cardiac things. So navuze ko hari tumors zimwe na zimwe zikora hormone ubundi zitari specific to the organ where that tumor is found. So the main examples are the tumors of the lungs, which produce hormones normally produced maybe in the adrenal gland, pituitary gland, and so on. So when that happens and the person presents with symptoms of maybe symptoms arising from overproduction of hormones, but which are not specific to the organ which should produce these hormones, we call it paraneoplastic syndrome. So the causes of SIADH, there is the primary brain injury such as meningitis, subarachnoid hemorrhage, and so on, which will cause this overproduction of vasopressin and so on. So you have also drugs which are listed here, amitriptyline, carbamazepine, imiryango nyinshi ikoreshwa. Okay, morphine urabizi n'umuti ukoreshwa mu buribwe cyane ukoreshwa muri cancers wabura cancer kwera uburibwe, njyawe niwo muti kugeza uburi hejuru ku isi mu kugabanya uburibwe. Iyo birenze aha ngaho nuko umuntu nukumusinziriza nta kindi uba wakora. So otherwise iriya miti yindi myinshi ikoreshwa muri mental health issues indera n'ahandi. So and you have many other causes here. Other causes CNS trauma, so I mentioned here, brain injury, pulmonary infection, and drugs such as cyclophosphamide. It is used for many purposes. In umwe mu miti ivura zimwe na zimwe muri cancer. Clinical features are based on the retention of free water. So there will be hyponatremia and the low serum osmolarity. Hyponatremia and the low serum osmolarity, mental status changes, and seizures. Hyponatremia leads to neuronal swelling and cerebral edema, and so on. So that's all. Ntabwo twatinze kuriya muti wa kuriya hormone ikorwa na oxytocin. So we understand that iri hasi hari ikibazo cyo kutagira milk, ni nabyo twavuga muri Shan syndrome yabyaje ari nabyo bizamo, ariko kandi ubaye mwinshi nabyo ushobora gutera ibibazo ku buryo umudamu utwite ashobora kugira ibise igihe kitageze kuri shaka. So question so far about the pituitary gland before we proceed with the thyroid. Okay, let's proceed with the thyroid gland. So nyango navuze ubushize tubona izindi head and neck tumors. So I said we shall come back on thyroid after, ariko mu bitabo bimwe na bimwe thyroid bazayishyira muri head and neck, yahandi bayishyire muri neuroendocrine. So ngira ngo ushaka kujya hose kubera ko amaserire yayo yose akora za hormones zitandukanye. So maybe it fits better here. So we go straight forward to the diseases. Fibroglosal duct cyst, I mentioned it when I mentioned the cyst which can arise in the neck. So it narabivuze ko ikibazo nuko ibi thyroid n'ururimi bikorerwa muri embryology biva ahantu hamwe. So bigenda bitandukana, thyroid ikamanuka, hanyuma igice kizavamo tongue kikaguma hejuru. That's why there is a thyro refers to thyroid, and the glossal refers to the tongue. So here it is a tumor or a cyst in which you have features or foci of thyroid, and then others are from the tongue. So you find the squamous epithelium, and then you find thyroid follicles. Ibyo rero biterwa n'iki? During the migration of the thyroid components from the tongue, some parts of the thyroid can be entrapped on their way here, as you see on this diagram. So the fibrosis then will remain here, while the normal thyroid has descended to its normal location here. So you understand that it is a developmental cyst, and it is not rare. We see many cases. We see many cases in our settings, and it presents as an anterior neck mass. And when you ask the patient to swallow, it moves. So apparently, to Zavango, it is a mass in anterior neck mass moving with swallowing. Where any mass moving with swallowing, usually it has a thyroid component in it. Ko naba ufite goita nicyo cyambere tubabwira dushaka kureba ko ari thyroid. You tell the patient to swallow the saliva, and then it will move upwards the mass. So here it can have a complication such as infection, or it can burst and be opened inside there. Another malformation or congenital anomaly, it is lingual thyroid. It means some fragments of the thyroid will remain here around just below the tongue. So persistent thyroid tissue at the base of the tongue, as I said, it is where the thyroid originates during embryogenesis. So it presents as the base of tongue mass, as you can see, sublingual and pre-laryngeal thyroid, and so on. You can have even substernal thyroid. Iri hasi cyane nanone. Hari abarwayi tugira baguatre bagoita bafite goita igaragara mu ijosi, hari n'uzi utayibona. Akavuga ngo ngiye binigiramo imbere ku buryo iyo mubwiye ngo amira amacandwe nibwo uyibona ishaka kuzamuka, uyibona izamuka iri inyuma ya sternum. So akenshi bimuniga ariko utayibona, but abenshi baba bafite mass igaragara kuri neck itari retrosternal. So these were developmental issues. Now going to hormonal problems. We start with hyperthyroidism. We will see also hypothyroidism. So I think you understand. Hyper, it is when there is too much production of the thyroid hormones. So diagram it is applicable to both hypo and hyperthyroidism. What we see is that in normal conditions, the TRH, which is produced by hypothalamus, will stimulate the pituitary gland to release TSH, which is thyroid stimulating hormone. I think TRH is the thyroid releasing hormone, things like that. So then TSH will stimulate the pituitary gland. This plus sign means stimulation. It will stimulate the thyroid gland to produce T4 and T3. And T3 and T4, when they are higher, where they are more than enough, let's say, in the bloodstream, they will have a negative impact on both the hypothalamus and the pituitary gland. So this is that feedback mechanism we mentioned before. And there are some who precise that T3 will act on the hypothalamus, while the T4 acts mainly on the pituitary gland. So abandi bakaba bati ni T3 no itari bound on the albumin niyo ijya kuri T, which will act on the hypothalamus. So this is the normal condition. So what happens in the hyperthyroidism is that there is too much T3, T4 production, and especially also there will be too much free T4 hormone production. So as a feedback, there will be low TSH and low TRH in the bloodstream. So nukuvuga ko iyo ubonye umurwayi afite ibimenyetso bya hyperthyroidism uko turabibona nyuma ugomba kureba izi hormone T3, T4, free T4, free T3, and then also you will do assays to measure TSH and TRH. Nibyo bizagufasha kumenya uwo muntu ubundi afite ikihe kibazo. Ko ashobora kuba afite goita idagize aho ihuriye na hyperthyroidism. And there are other tests that we shall see which are done. So the basic principles of hyperthyroidism, there is increased level of saturating thyroid hormone. So this increases the basal metabolic rate. Birumvikana ko umuntu afite thyroid hormones, mwita metabolic rate as you saw in physiology, it will go high. No ukuvuga ni umuntu uzaba ukeneye, bajya babivuga n'abarabigeze za nutrition batari nabo muri healthcare profession nyisha ku YouTube na hene sanga bivuga hari abantu bigira metabolism iri hejuru. Ni ukuvuga yariye asonza vuba kwa ko umubiri we ubikoresha vuba n'ibindi. Hakaba n'urya uyu munsi akumva yazongera kurya ejo bundi. So bagira n'ibindi bimenyetso hanze bitandukanye. N'undi uzasanga uyu nguyu ukenera kurya vuba anananuka vuba kubera ko amasozi ze ziba iyo atinze kurya ibyari stoka aho ngaho birakoreshwa mu proteine and so on. So usanga rero abantu bafite hyperthyroidism bananuka ubwa ngo babyimwe nubwo arya kenshi nubwo agira apeti nyinshi. So due to synthesis, increased synthesis of and sodium, potassium ATPase increases sympathetic nervous activity, you increase the expression of these adrenergic receptors and so on. So what are the signs? So they have a broken hair or hair loss, enlarged thyroid gland, so afite ikintu kimeze nka goita, so haba habyimbye. Kuba habyimbye rero bishobora guterwa n'impamvu nyinshi harimo hyperthyroidism cyangwa se ni ikibazo wenda cyo kubura iodine nk'uko turi bubone, niho nk'umuganga uzirukarira icyo kibazo afite. Kubyimba kwa thyroid ntabwo buri gihe bivuga ko ari umwingo, nubwo nyine ko muri rusange tubyita. Ushobora kuba ari iodine deficiency cyangwa ikaba hyperthyroidism cyangwa se ikaba ari inflammation, or it can be a tumor. So it will be up to you as a medical doctor to know or to discern which is the reason for that. So nervousness, so n'abantu biyanza cyangwa ibikibyo byose bafite badasinzira, depression, weight loss, strong feeling of hunger. So I think I was mentioning that they usually also experience diarrhea. They have this I mentioned, increased heart rate, arrhythmia, high blood pressure. They have muscle cramps, muscle weakness. They can have a cycle disorders and have a menstrual cycle zabo. Warm, moist skin, increased the body temperature. It is another sign. Fragile fingernails, shaking hands. So what it is. So birumvikana ko ibimenyetso ubibonye, you can think about this and then can request for measuring the hormone T3, T4, TSH, TRH. So clinical features, I think I was mentioning them on the diagram. I don't need to repeat. Ariko ibindi byiyongeraho nuko they have heat intolerance and sweating. When I see a patient with an enlargement of thyroid, ikintu mubaza ukunda kugira apeti, wumva ushaka kurya cyangwa se ushaka kurya, wumva yano hashyushye aribyo bikubera byiza cyangwa se ariwe bikubangamira kurushaho. Ese ibiro byawe byaragabanutse cyangwa byiyongeye? So ibi byose muri mubaza kugira ngo menye niba bifite hyperthyroidism. So other things that are hypocholesterolemia, arrhythmia like twabivuze and so on, bone resorption with hypercalcemia, they will have a risk of osteoporosis and so on. So ibindi yango twari twabibonye hejuru. So ikindi kibaranga na kitavuzwe ari hejuru nuko amaso yabo asa naturumbukamo akaza imbere. So this is a sign of that hyperthyroidism. So muri rusange bazaba bafite goita. So goita ni ukubyimba kwa hariya, ariko ugomba kumenya ko kubyimba kwatewe n'iki. So mwaba uzabona bavura bitandukanye, uvuga ngo kubera iki uriya wamuvuye gutya. So maybe some of you will do endocrinology. You know that we have now subspecialty programs in at the University of Rwanda. So abize medicine interine harimo bari kwiga endocrinology. Okay, so they are they are usually in this field. So I think this week they are. The coordinator told me that they want to be rotating in pathology for thyroid issues. When we do final aspiration or other procedures on the thyroid, they want to rotate in our department. So Graves' disease ni abana abarwayi bafite hyperthyroidism ariko itewe n'iki? Mu gihe ahari ahandi muri primary, what can you call primary hyperthyroidism, maybe the issue is with the pituitary gland, ariyo ituma habaho TSH nyinshi cyangwa se ikagabanuka, T3 T4 zikazamuka and so on. Ariko muri Graves' disease clinically they will look the same, but the difference is that here there will be autoantibody. So this is an autoimmune disease which stimulates TSH receptor. So bizasa naho izi IgG ziza stimulating receptor yo ikazakira igira ngo ni TSH. So bityo rero uzasanga umuntu we yifite TSH nkeya ariko still agire akomeze kugira T3 na T4 zizamutse cyane kubera ko the receptors are increased. So this will lead to increase the synthesis and the release of thyroid hormone, and this is the most common cause of hyperthyroidism. Classically, it occurs in women of childbearing age, 20 to 40 years, around there. So on histology, we see irregular follicles here, and you see, so hejuru normal thyroid, you can see a follicle. Ibi biri pink hano ni choroid. So nkuko mwarize muri physiology uko bigenda, choroid iri hano ibirimo iodine. So these cells around these blue ones, they are follicular cells. Icyo zikora zifata zirya iyi choroid, ziba zishakiramo iodine kugira ngo zikore T3 and T4 again. So rimwe na rimwe uranabibona nkanga hari utuntu tw'umweru muri kubona kuri izi follicles just below around these blue cells. Ahangaha abaye umweru nuva hari choroid, aya maserere arayirya, nicyo babisobanura. Hari igihe usanga aya maserere ayirya cyane, ugasanga hano n'umweru hanini, ahabaye umweru ni hanini. So in Graves' disease what happens, murabona ko amaserere noneho yabaye menshi ku buryo follicles zuzuye amaserere, choroid ni nkeya y'ubwayo. Choroid murabona ko ari nkeya, naho iri hano yabaye umweru, habaye umweru kwa choroid yariwe n'ayo maserere. So there will be irregular follicles with scalloped choroid and chronic inflammation. So clinical features n'ubundi bya exophthalmos irimo, cyangwa ku amaso yo kubyimba cyangwa kubisa nazi imbere birabyimba. So hari ababifata nka trade kugira amaso manini cyane abakobwa cyangwa abadamu azi imbere nini, ariko hari abwo birenze urugero nyine bikaba ikibazo, as we see it in here in Graves orbitopathy. So diffuse goiter, they have a constant TSH because of the constant TSH stimulation. twabibonye. Exophthalmos ni uko kubyimba amaso aza imbere. Pretibial myxedema, so ese naho mu maguru huzuye ibintu bimeze nk'amazi anyenya amazi cyangwa n'indi amazi mu maguru, but we shall come back on this. So I think the explanation is here for the myxedema, why it is developed. Otherwise, we have other signs here of Graves' disease. So here they say the Graves' disease is the most common reason for hyperthyroidism, meaning that when someone comes to you with hyperthyroidism signs and symptoms, then the first thing you must do is to exclude this, because it is the most common one. Uzajya mu bindi, or after excluding the most common pathology. Okay, so the laboratory findings, we have increased total and free T4 and decreased TSH, because the free T3 downregulates TRH receptors in the anterior pituitary to decrease TSH release. So free T3 will have we have a negative feedback on the TSH release. Other laboratory findings are hypocholesterolemia, increased serum glucose, and the reason. So the treatment will involve to administer beta blockers, thioamide, and so on, or radioiodine ablation. Radioiodine ablation. So this is just the pathophysiology, as we said. So have found the gland and the follicular cells, and the choroid is inside the follicles. So depending on the TSH, we will have a certain concentration of T3 and T4. So in Graves' disease, T3 and T4 are increased, and there is also thyroid cell proliferation. So as you see here now, what happens, we have this peptide being engulfed by antigen presenting cells like macrophages with their major histocompatibility proteins, which will now attach the T cell, T lymphocytes, and these T lymphocytes, they can also act on plasma cells. Plasma cells will produce antibodies. Then these TSHR autoantibodies, R means the receptor, TSH receptor, they are shown here. Then autoantibodies means they are autoantibodies coming to stimulate the body's own TSH receptors here. So they will be produced by these plasma cells. But you see that muri izi diagram yakumuzayamona hajeho akakantu kameze gutya, nukuvuga ko it doesn't stimulate, it inhibits. Nukuvuga ko T regulatory cell, it will inhibit this process. It will inhibit the activation of T cells or the activation of the plasma cells to produce this. So bivuga ko uyu muntu uramutse umuhaye T regulatory cells nyinshi, autoimmune disease itagaragara ubundi. So this is known. So there is what you call then thyroid storm. Ngira ngo ubushize nabuze ibyitwa cytokine storm tureba kuri COVID-19, aho hakorwa cytokines nyinshi za interferon, za interleukins nyinshi zigatera ibibazo, harimo fibrosis of the lungs and so on. So hano noneho bivuze thyroid storm ni ukuvuga haza too much production of hormones, of thyroid hormones. So this is a potentially fatal complication due to elevated catecholamine and massive hormone excess, usually in response to the stress. So it presents with arrhythmia, hyperthermia, and vomiting with hypovolemic shock, and so on. Treatment is, so here we have a propyl, TO, uracil, beta blockers, and steroids. So here we have more of details when you have endocrinology course about the treatment. So apart from the Graves' disease, another reason of hyperthyroidism is matinodira goita iyiterwa no kubura iodine usually due to relative iodine deficiency. So abarwayi iyo babarira ikindi nkunda kubaza abantu bafite goita, so afite thyroid ibyimbye nabo baza gukunda kurya iki. So because it is known, iodine en principe ntabwo twagombye kuyibura kubera ko muri uyu munyu bateka mu gikoni ubusanzwe nubwo harimo sodium na chloride bongeramo na iodine. So ibyo bivuga ko nta muntu wagombye kugira deficiency kuri iodine niba arya uyu munyu usanzwe bateka mu bikoni. So ni ikiro gishobora gutuma umuntu agira deficiency relative 1 or secondary 1 kandi mu byo turya umunyu haba harimo iodine. So hari ibiribwa bifite ama chemicals which will compete with iodine to be absorbed at the intestinal level. So meaning that when you eat them, there is also iodine. When they reach the intestine, small intestine, where absorption of nutrients happens, so there's other chemicals will compete with iodine kandi bizayinesha ngo bakunda kuvuga ko irusha inshuro nyinshi cyane kuba competitive birusha iodine. So ibyo biribwa ari byinshi ni ibijyanye n'isombe, amashu, intoryi, ibintu nk'ibyo. So ariko bigaterwa n'uburyo byatetswe, ntabwo ari uwo ari wese ubirya. Gusa iyo ubabarisha ko bati jewe hafi buri munsi ndya isombe cyangwa se nariye amashu cyane, ibyo byo barabikubwira kandi atetse mu buryo wenda butari appropriate. So then these people, they have usually non-toxic or a thyroid condition. So non-toxic, ubundi tuba ko umuntu afite toxic thyroid igihe afite too much hormones. So aha rero icyo bivuga abafite hormones ntabwo ziba zizamutse, ntabwo iyo tuvuga hormones za thyroid ni T3 na T4 ntabwo ziba zizamutse. So kubera ko ziba zitazamutse rero bakavuga ko afite euthyroid or non-toxic thyroid. Babibona bate? Ugeze urupima mu maraso birumvikana mukareba niba they are in normal ranges. If not, then if they are in higher ranges, concentration titers, so you mean there is a toxic goiter. So we go to hypothyroidism. So pathomechanism rero ya matinodira goita itewe na deficiency muri iodine nta kindi nuko niba thyroid twabonye ko ikora T3 na T4 ibikoresheje iodine ikura muri choroid. Iyo rero umubiri bigaragara ko iodine ari nkeya, icyo as a consequence umubiri urekura TSH nyinshi. TSH nyinshi ikatuma habaho too much production of too much proliferation of follicular cells. Follicles zikaba nini cyane kugira ngo haboneke choroid ihagije kuko ya choroid ari izavamo iodine. Ariko ikibazo kirushaho n'ubundi gukomera kubera ko n'ubundi still there is too much choroid production but there is no iodine. So TSH igakomeza ikiyongera and so on. So T3 igakomeza ikaba nkeya na T4 zigakomeza kuba nkeya. So as a consequence rero uko bigenda niki nuko follicles ziba nini zijyaho zikaba ruptured. When there is a rupture, it means there is a destruction of somewhere, some vessels has a hemorrhage. So byose ni ibintu tubona kuri histology. So ibi ni ibintu they are very frequent in our hospital. So ugasanga habayemo hemorrhage, harimo fibrosis, harimo calcifications, cholesterol clefts and so on. So this is what is. So hypothyroidism. So yeah, diagram turayigarukaho tukaba twarebye normal and hyperthyroidism. Now hypothyroidism ni igihe hari low T4 and free T4. So ikindi kibajyanye n'iki nuko aho TSH ya feedback mechanism, because there is low thyroid hormone, then TSH will have to be increased and of course TRH. So indwara zirangwa na cyangwa uburwayi cyangwa se conditions zirangwa na hypothyroidism, iyo bita cretinism, n'iy'abana, noneho abakuru ngira ngo ibyo bita mu gifaransa ni nanisme na cretinisme. So cretinisme ni ko bana abakuru bagira ibyo bita nanisme. So mu cyongereza banza nanisme bidakora hakoreshwa milisidema nk'uko turi bibona. So uzasanga abana badakura, short stature, kuba tugufi, skeletal abnormalities, worse facial features, enlarged tongue, umbilical hernia, and mental retardation. Because thyroid hormone is required for normal brain and skeletal development. So the causes include maternal hypothyroidism during early pregnancy, thyroid agenesis mu mwana, this hormonogenetic goiter mu mama we, and or iodine deficiency. Okay, so this hormonogenetic goiter is due to congenital defects in thyroid hormone production, most commonly involves thyroid peroxidase. So maybe anga iodine bihari ariko n'ubundi still hormone ntiko. So yaba upimye iodine urasanga ayo ayifite mu maraso ihagije, ariko ikibazo ari thyroid hormone chiefly typhoid uko bihagije. So myxedema, as I was saying, when there's hypothyroidism which comes during older childhood or during adulthood, it produces myxedema. So it is like a counterpart of cretinism in children. So the causes are iodine deficiency. There is a Hashimoto, we shall see it, thyroiditis. It is a type of inflammation of thyroid. Aho usanga harimo lymphocyte nyinshi. So other causes include drugs, surgical removal, or radioablation of the thyroid. So the signs will be low body temperature and blood pressure, triggering infection, body immunity will be low, of course, shallow or slow breathing, absent or slow reflexes as so changes in mental status, pulse below 60 beats per minute. So these are the main signs. So clinical features are based on decreased basal metabolic rate. So basal metabolic rate nabivuzeho kare, ufite hyperthyroidism ararya cyane, donc umubiri kugira metabolism yihuta. Uyu nguyu we iri hasi, so uzasanga ari umuntu ufite normal appetite cyangwa yagabanutse ariko akagira ibiro byinshi. Mu gihe ufite hyperthyroidism twabonye ko agira apeti nyinshi ariko ibiro bike. Slowing of mental activity, muscle weakness, cold intolerance. Mu gihe hyperthyroidism atinya ubushyuhe, heat intolerance. You understand that difference. Bradycardia, only after tachycardia, oligomenorrhea, hypercholesterolemia, constipation, mu gihe twabonye afite diarrhea. So you understand that ari ibintu biri opposed cyane. So for these functional aspects of the thyroid, so maybe if you have a question, you can ask before we go to the inflammations. So, seems no question. So, proceed with thyroiditis, which is inflammation of the thyroid. So, the first disease we see here is the Hashimoto. So, ahangaha harimo amazina. So, Hashimoto murumvikana izina ry'aba Japanese. So, ariko ishaka kuba nuko the types of inflammation here in thyroid biri yose ifite izina bijyana. Hari Hashimoto, hari Liedel, hari Endocrine, as we shall see. So, there are 3 types of inflammatory conditions in the thyroid. So Hashimoto is autoimmune destruction of the thyroid. Graves' disease, it is autoimmune, but it doesn't destroy. It rather stimulates the follicles. While here, Hashimoto destroys the follicles. So Most common cause of hypothyroidism, because you understand they will be hypo because the follicles are destroyed. Therefore, there will be low production of hormone or of thyroid hormones. Although here the iodine levels were adequate, iodine izamuka mu maraso nyine ivuye muri intestine izaba iri no in blood circulation, but muri ntizaba ifite ahantu henshi ijya muri thyroid aho izajya, therefore most of the follicles will be destroyed. Initially, they will present with hyperthyroidism. Why? Because there will be a follicle damage. There will be follicle damage, and then the other follicles will try to compensate and so on. But afterward, that it will progress to hypothyroidism. That compensatory mechanism will be izatsindwa kubera follicles nyinshi zaba zamaze kwangirika. So there will be no possibility to compensate the lost ones. So they will present with low T4 and high TSH. There will be antithyroglobulin and the antithyroid peroxidase antibodies, which will be present, and these are signs of the damage. So I think this will help. Umuntu ufite hypothyroidism ni ukureba ni ikibazo cha iodine, ni ikibazo cha destruction of the follicles, maybe by Hashimoto's thyroiditis. So you see things you will look for. So there will be enlargement of the tongue, memory, rhabscess, depression, goiter, and so on. So we have signs here, different one, enlarged and inflamed underactive thyroid. So the chronic inflammation, as we see on this diagram, the follicles small and few follicles. Otherwise, these blue cells, most of them, they are lymphocytes, which have destroyed follicles. So even the remaining follicular cells which have survived this inflammation, they will be transformed into half cell, which we call zoonotic metaplasia. So there will be increased risk of B-cell lymphoma. Because there is accumulation of lymphocytes, most of them are just young or immature lymphocytes, so it will be easy for them to transform into a cancer from lymphocyte, which is lymphoma. So there will be enlarging thyroid gland. So ni ukuvuga afite ni nk'aho ari goita harabyimbye, ariko wareba ugasanga za hormones ziri hasi. There is normal iodine, and there is antithyroglobulin and so on antibodies, which will indicate that there is the auto-destruction of the thyroid. So the second type of inflammation is granulomatous. Niyo bita dequerven. So no umuntu wita dequerven. So that granuloma, you can identify here. There is a giant cell, multinucleated giant cell with you see the nuclei of cells here, and the inside there is no cell inside. So tuberculosis. So they say that it follows usually a viral infection, and it seems Epstein-Barr virus is one of the most common causes of this, the Quervain thyroiditis. So they say that it is self-limited. How come with viral diseases? Usually they are self-limited. Self-limited means it can cure itself without any treatment. The issue is that you usually don't know who can progress or who can resolve spontaneously the inflammation. So the third type of inflammation is Rieder. So amazina y'abantu hari Hashimoto, hari the Quervain, and Rieder. So in here we have fibrosis. So too much fiber deposition of collagen fibers. And of course, this patient will have also hypothyroidism with a hard thyroid. Ngira ngo ukora palpation nanga ushobora kuyibona mugeze ntabwo ziba ziri soft, but this one will be very hard because of the fibrosis. So it mimics carcinoma on clinical examination. But here the patients are younger and the malignant cells are not present on histology or cytology. So the next part of thyroid is to see the tumors. So going back to the principles of histology in thyroid, as we saw, thyroid is composed of mainly thyroid follicles. Each follicle is composed of the follicular cells, and in between, in the lumen, you have the choroid, which is should be rich in iodine. Ariko hari izindi selile ziba ku ruhande, ahangaha bita C cells. C, probably because they produce a hormone called calcitonin. So this is C should stand for calcitonin. So it means we have follicular cells producing T3 and T4, and you have C cells producing, or parafollicular cells which produce calcitonin. So that is in general the cells you have here. So isn't it have 10 in very general in vessels, in fibroblasts, in nerves, ibyo ni ibisanzwe. So from follicular cells we can have which tumors? We can have the way differentiated thyroid cancers are papillary thyroid carcinoma, ari nayo nyinshi, follicular carcinoma, we have other cancers, and when it is undifferentiated, we call it anaplastic thyroid carcinoma, which is very deadly. So I think this, then the cancer from this cells, C cells will be called the medullary thyroid carcinoma. So izi nyinshi turazibona gensiri yiganje ni papillary carcinoma, ariko this Wednesday I had a patient with follicular thyroid carcinoma. So usually presents as distinct solitary nodule. So ibyo bivuga iki? Nubona umuntu afite thyroid ibyinshi ukabona ni nodule imwe yonyine, be very careful. Usually it is a tumor. It can be a benign tumor or a cancer. Ikindi turavuze hano nuko hari benign tumor hano yitwa follicular adenoma. So we have follicular carcinoma and but also have follicular adenoma hano ntabwo one is cancerous. So when you see one, a solitary nodule in thyroid, be very careful. Nose. When you see bilateral nose polyps, usually it is inflammatory or allergic. But when it is unilateral, usually it is a tumor. So you do what you call iodine radioactive uptake studies are useful to further characterize the nodule. So bivuga iki rero, nubona umuntu afite nodule imwe uzakora ibi bita nuclear medicine. So n'abantu they are applied nuclear, ni nkuko bakoresha zera bya radiation cyangwa se abantu bakoresha bya kora abakora bya bomb atomic, ibintu bijyanye n'ibyo bya uranium. So hari application yabyo kuri medicine ikoreshwa cyane cyane ni hanga kuri thyroid. So ni iki rero ukora, umuntu umuha iodine ariko iri radioactive. Kugira ngo ibe radioactive rero iba ifite navuga electro cyangwa protons zitandukanye n'isano. Ngira ngo iodine igira 130, if you remember. Ngira ngo nimwe mwibuka shimivu chemistry igira 130, ariko hanga ni 139 cyangwa se igira 29, I don't remember well. That there is a difference in this number 131. So ibyo rero bituma iba radioactive, ndetse ibitse nk'aho ari free radical, ariko kubera ko bayishyize ku bindi bintu, ku zindi chemicals, ntabwo yangiza umubiri. So icyo gihe rero uyinjecta umuntu cyangwa ukayimuha mu maraso, ikagenda yagera muri thyroid ugafotora. Kwa kuri radioactive, ikintu ufotoza kiba kiri sensitive to anything which is radioactive. Then iyo usanze rero thyroid yayifashe cyane, icyo gihe bavuga ko ari hot nodule. When there is increased uptake of this radioactive iodine, you say the nodule is hot. So when it is hot, usually it is just nodira goita yanitewe na ishobora kubiterwa na deficiency in iodine, or it is a Graves' disease. When there is a decreased uptake, or we call it cold nodule, so it is seen in tumors, either carcinoma or adenoma. So nicyo ngicyo birafasha kandi birakorwa cyane aho bazifite, aho bafite izi facilities zo kubikora. So nuclear medicine, urabona abantu bavuga ngo bashaka kwiga nuclear medicine, iki ni kimwe mu bintu bya mbere agomba kwiga. So ibindi bashobora gukora biga nuclear medicine ni tube nko muri breast cancer. Umuntu ufite breast cancer cyangwa any other cancer, hari ubwo ushaka kumenya niba yaragize metastatic cells. Iyo ari nyinshi zikagenda guhora amase nini, okay, CT scan irabibona n'ibindi, ariko iyo zikiri nkeya, ari nke cyane ku byo CT scan tutabasha kuzibona, n'ubundi wohereza radioactive elements which now you will detect using some instruments. So ibyo nabyo barabikoresha. Niyo mpamvu uzajya wumva hano bavuga ati twe dufite PET scan. Iyo PET CT scan iba yo ifite ubwo bushobozi. So we don't have it here, of course, but it helps much. Kwari igihe dufite umurwayi yenda yakoherezwa nko mu Buhinde, twebwe hano X-ray, CT scan, ultrasound, MRI zaragaragaje ko nta metastasis zibona, ariko bakora PET scan bagahita babona uduserire duto cyangwa utubume tw'uduserire duto cyane twaramaze gutambuka, so bakamenya uburyo bamuvura. So iyo ibaye negative, usually it is really negative. So therefore, this cold and hot nodule, you understand their implications. When it is cold, it is worrisome. It may be a cancer or an adenoma. So now, that was just general principles about the tumors of the thyroid. Starting with the follicular adenoma, which is the benign tumor. It is a benign proliferation of follicles surrounded by fibrous capsule, as we see here. So on the right side, this is a diagram. It is not a true picture. So this is how the normal thyroid looks like. And then you see a capsule, and below the capsule you see a tumor which is very blue. So the follicular cells here are more blue than in the normal counterparts here. So here we see now a true histological picture on the left. So I'm going to the follicular follicles, and you have here, you see that it is more blue. It is more blue because there are too much follicular cells, no choroid. Well, follicular cells ziba proliferative cyane, zikuzura naho follicles zari kugiye nta follicles ubone, cyangwa ukabona microfollicles duto cyane. So usually when we see it, so the case I was saying we had this week of follicular carcinoma. So ubwa mbere baketse ko ari follicular adenoma. So and njyewe ndavuga nti I'm not sure. So nsaba ko processing blocks nyinshi zishoboka zivuye muri thyroid. So then the process, I think 8 more blocks. So we found that somewhere the capsule here was breached by these cells. And ikibazo muri thyroid tugira muri histology nuko cancer cells here, they don't look abnormal. Ziba zisa n'izindi. Ikintu ureba gusa ni imyitwarire yazo. Imyitwarire yazo ni ukureba niba zishwanyura capsule cyangwa se niba zinjira muri vessels. Nicyo dufasha gusa kandi tubone ko ari follicular carcinoma. Niho twitandukaniza na adenoma. Otherwise the cells will look alike. So that was follicular adenoma. Then we go to papillary carcinoma. So it is also a cancer arising from the follicular cells. Ariko ahangaha the follicles are not made. Ahubwo ikora ibiri papillary, ni ukuvuga amaserire menshi agenda akikije akantu kameze nk'akadodo katukita fibrovascular core ari ku ruhande rwaho. So this core usually contains very small blood vessels which will bring nutrients to these cancer cells. Ikindi kiranga amaserire nuko usanga their nuclei are like empty, no chromatin. You don't see chromatin. So to get inclusions in nuclear inclusion, ariko gituma ibi bita ngo orphan ani eye. So ikindi dukunda kubonamo ni calcification. Some bodies which are a single cell calcification as it is shown here. Hari n'igihe tura muri chromatin tugasanga harimo akarongo kameze nk'inkingi yambukiranya nucleus, ibyo bita grooves, nuclear grooves. So it is not easy to see on here. Kubera ko njye mbimenyereye ndazireba ariko it is not easy to show that on here. On microscope it is easier. So more important now, ikintu mugomba kumenya kuri thyroid cancer nuko papillary carcinoma metastasizes through lymphatics, while or lymph node, while follicular carcinoma, as we shall see, will metastasize through blood vessels. This is very important for you to know. Is a trick cyangwa se patuntu umuntu aba agomba kumenya to be a good healthcare professional. So follicular carcinoma now is professional follicles surrounded by fibrous capsule with invasion through the capsule. This is what I was explaining with the case we had this week. So invasion through the capsule will help to distinguish follicular carcinoma from adenoma. I was explaining that entire capsule must be examined microscopically. Ni nayo mpamvu nasabye ko ba processing blocks so thyroid yose tukareba niba nta hantu hari invasion of the capsule. So final need aspiration nta kintu igaragaza kuba ko amasarira abasa neza byose aba asari nk'ari benign, icyo ubona gusa nuko yabaye menshi. Kwa yabaye menshi ho bishobora kuba adenoma cyangwa carcinoma. Mpamvu uzajya usanga we report, and this is internationally on cytology we cannot say follicular carcinoma, we say follicular neoplasm. Iyo tuvuze neoplasm rero ishobora kuba adenoma or carcinoma. Ngira ngo this is very important. Hari abaganga benshi iyo uvuze ngo neoplasm bumva ko kari cancer. It is not cancer, it means a tumor. It can be benign or malignant. Hari rero prior to reporting this is a thyroid neoplasm. Bagahita bavuga ngo umurwayi wacu bavuga ko afite kanseri, then bakakora ibintu bitari appropriate. Just because they don't know to interpret that simple terminology. So metastasis, as I said, occurs hematogeneously. This is a clue you must know. Follicular carcinoma metastasizes through bloodstream, papillary carcinoma metastasizes through lymphatics. So medullary carcinoma yo iva hehe muri za C cells, parafollicular C cells, ni nabivuzeho irangwa n'iki kubera ko these cells they produce too much amyloid. Amyloid uzasanga ari afite amyloid ahantu hari pink. This is amyloid deposit. Then the blue cells, these are the cancer cells. So usually it is not a difficult disease to diagnose. It is very simple. Another thing you will find in this patient, they will have a high calcitonin because this tumor will produce too much calcitonin. And then because, as you know, calcitonin, its function is to decrease the calcium in the bloodstream. Uzasanga rero abafite calcium nke cyane mu maraso. So turi bubone nyuma calcitonin ituma calcium yoherezwa mu magufa ikaba nkeya mu maraso. Noneho parathyroid hormone does the opposite. It makes sure there is enough calcium inside the bloodstream, and sometimes parathyroid hormone will destroy bones in order to acquire enough calcium for the bloodstream. So they have opposite functions, calcitonin and parathyroid hormone. So medullary carcinoma, usually it is also associated with multiple endocrine neoplasia familial syndromes. So nukuvuga abantu usanga mu muryango yabo bakunda kugira parathyroid problems, thyroid problems, adrenal gland problems. So ibyo byatumye habaho classification yitwa MEN. MEN means multiple endocrine neoplasia. Ugasanga umuntu umwe afite neoplasia or tumors in different endocrine organs. So we have three types. We have main one. Main one, it is characterized by pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors. Main 2A, it has, there is no pituitary adenoma you can see, but the parathyroid hyperplasia and the medullary thyroid carcinoma, hakabaho na pheochromocytoma. This is in adrenal gland. So no kuba hano hari ikibazo muri adrenal gland, muri thyroid no muri parathyroid. Mu gihe muri main 1 hari pancreatic issues na pituitary gland, izi zitaboneka muri main 2A. So muri main 2B harimo ibindi bintu, malphanoid body habitus, mucosal neuromas. These are big tumors arising from neurons. We have a medullary thyroid carcinoma again in the pheochromocytoma. So many 2A and 2B bijya gusa uretse the Marfan syndrome, I think you know it, and the mucosal neuromas which are added. And there is a mutation here, red oncogene. So the other carcinoma, which is anaplastic, meaning that the cells are not differentiated. So akenshi ubonamo selile zimwe zisa na epithelial cells, others are looking like stromal cells, but this is really a very aggressive tumor. So I remember there is a case we diagnosed then in because thyroid, when thyroid disease, when it becomes surgical, ugomba kubagwa itagishoboye gukurikiranwa n'abo muri endocrinology cyangwa internal medicine, bahita bohereza either muri ENT, ear, nose and throat, cyangwa ORL, cyangwa se bakabeza muri general surgery. Nabonye it depends on the hospitals. Ariko icyo nabonye uwo murwayi wari ufite, twabonyemo na plastic carcinoma, nuko abo muri ORL nibo bamukurikiranaga bahise bamucyura vuba. Kako nta kindi benda kumukora, nta miti, nta bashobora kubagwa, so there was no other option. So kuba bamubwiye nta kindi ushobora gukorerwa hano mu Rwanda keretse mufite ubushobozi mukajya mu mahanga, otherwise keretse kumufasha imiti y'uburibwe. So it is really a very aggressive tumor, killing very quickly. Nyango tukiri kuri nihibuka mvuze ibyo ama department kuri breast nabivuze ko hari mu bitabo bashyira muri bimwe na bimwe muri female genital system so on. So ibyo byatumye mu bihugu bimwe na bimwe breast tumors cyangwa breast diseases zivurirwa muri gynecology, izindi mu bindi bihugu bakayivana muri general surgery kubera bati no ntabwo ari indwara y'abagore gusa, so bakajya muri general surgery. So mu Rwanda rero tendance bihari, so nibwira ko ngitangira akazi hari hakiriho ambiguity, bamwe bajya muri surgery abandi muri gynecology, ariko ubu it is clear in Rwanda breast diseases are treated, at least in teaching hospitals are treated in surgery, not in gynecology. Ariko ndabizi muri district hospitals, even at Muhima hospital, it is breast cancers are dealt with in gynecology. So that you must be aware. Niba ariho umweza sashka ntuzamwereze muri gynecology, cyo cyazanyura mu nzira zigoranye. Zamweze muri general muri surgery, cyane ko dufite plastic surgery aho babaga iyo bakuyeho ibere bagakora reconstructive surgery, bagakora akandi ikindi kintu kimeze nk'ibere. So I explained that the anaplastic carcinoma has a very poor prognosis. Any questions about the thyroid? Okay, so you are keeping quiet. So maybe we break from here. So we are left with about 35 slides. So we shall resume then in the afternoon, and maybe we'll take 1 hour to finish this presentation.